is a section from the prostatic urethra and the prostate.
Figure 18.10, prostate gland and prostatic urethra, stain hematoxylin and eosin, low magnification. 1. Prostatic urethra, 2. Prostatic sinuses, ejaculatory ducts, smooth muscle bundles, prostatic gland, transitional epithelium, colliculus seminalis, utricle, ductus of prostatic gland, fibromuscular stroma, prostatic gland with concretions.
This is the prostate. This is the rectum. So you can go through the rectum, do ultrasound, and then take a biopsy from the lesion. This is transrectal ultrasound guided biopsy, TRUS. The other method is go through the urethra, transurethral resection, isn't it? Top of prostate. So these are all the two methods by which we can get the prostatic tissue. And TRUS is done mainly when they are suspecting malignancy. And as you all know, prostatic malignancy is a disease of the periphery. Whereas TOP, whenever there is a urinary tract obstruction, it is more like a benign condition. But sometime in TROP itself, transurethral resection itself, you can see the cancer. And those cancers are higher stage cancers. From the periphery, they are arising and they are coming to the center. And another important thing you have to remember is PSA level. PSA level is high in cancer and it is a normal or moderately high in benign prostatic hyperplasia. And the normal value is less than 4. 4 to 10, we don't know what is, how to interpret it. And more than 10 is favors malignancy. So these values you have to remember. Less than 4 benign, more than 10 malignant. 4 to 10 we don't know. So that's that's where they do PSA level, and most of the PSA is bound to albumin, and there are some portion that are not bound, and that is known as free PSA, and that ratio is very important. If the free PSA is more, it favors benign.
Figure 18.12, figure 18.11, prostate gland acini and prostatic concretions, stain hematoxylin and eosin, medium magnification. 1 is glandular acini, 2 is excretory ducts of the prostatic gland, 3 is smooth muscle bundles, 4 is prostatic concretion, 5 is glandular epithelium, 6 is prostatic concretion, 7 is fibromuscular stroma, 8 is again prostatic concretion, 9 is prostatic secretion, 10 is connective tissue folds.
Prostate is very similar to breast. See it in low power, most of the prostatic glands are arranged in lobules. The ducts will come from the lobules, they will come and they will drain into prostatic urethra. Within the lobules, you see glands of varying sizes. Remember, I told you prostate will be having, like in thyroid, glands of varying sizes and shapes, but the lobularity is maintained. Prostate shows 2 types of cells. One is secretory cells, which are more like cuboidal or columnar cells, and then we get the myoepithelial cells in between the secretory cells and basement membrane. Even though this is myoepithelial cell, in the prostate we call it basal cell because it is basally located. This understanding is very, very important because prostate cancer gives rise to only the proliferation of the epithelial cells. Myoepithelial cells should not be there. When you see a prostatic carcinoma, number 1, the glands will be of uniform size, shape, distribution. Number 2, you see only one layer of cells. That myoepithelial cells will be absent. And when you look into this cell, these are more like a columnar cell or high cuboidal cells with vesicular nuclei, and all of them will show prominent nucleoli. So prostatic cancer is diagnosed by number 1, architecture, number 2, cytology. In the architecture, they will be of uniform size, shape, distribution of the glands and the absence of myoepithelial cells or basal cells, absence of basal cells. Cytologically, they will have prominent nucleoli. These 2 are major criteria. There are some minor criteria like glomeruloid bodies, crystalline structures. IHC will help. We have some markers for the epithelial cells and we have IHC marker for the myoepithelial cells also. So the epithelial cell marker should be positive and myoepithelial marker should be negative. The most common epithelial marker now we use is, previously we used to have PSA and other thing, and I think we use NKX. For myoepithelial marker we have P40. Most of the IHC markers, they tell the cell of origin. They may not tell whether it is benign or malignant. For example, NKX 3.1, it's a prostatic origin. Whether it is a benign epithelium or malignant epithelium, it won't tell. And those sort of markers will help in metastatic situation. For example, there is a vertebral lesion. You see some epithelium that are NKX 3.1 positive. Then you can say it is prostatic cancer because normal prostatic epithelium should not be seen. But within the prostate, it may not tell whether it is benign or malignant, and 95% of the markers are lineage. They tell what is the origin of cells. But luckily now we are having few markers that are staining only malignant epithelial cells, racemes, that Amancor and P40, and they can have some other basal cell marker like SMA to diagnose those cocktail of markers to diagnose benign or malignant prostatic gland. Another one good example for malignant marker is glypican 3 for hepatocellular carcinoma. Normal hepatocytes should be negative for glypican 3, whereas hepatic neoplasms will be positive for glypican. And this is the cross section of the penile region. The only thing you have to remember is we have corpus cavernosum and corpus spongiosum. The urethra is traveling in the corpus spongiosum. Corpus cavernosum is the two other pillars there. I already told you, whenever you see penile cancer, you have to see, is it involving the urethra, is it involving the corpus spongiosum, and is it involving the corpus cavernosum. Now we are coming to female genital system. You all know the things you have to remember are this is vagina, cervix 2, body of uterus 3, fallopian tube 4, and ovaries 5. There are only 5 structures. Ovary is very easy. Ovary is number 1, you have to remember the lining epithelium. Number 2, you have to remember the germ cells. And number 3, you have to remember the stroma. You all know ovary is divided into cortex, where you see the germ cells, and medulla, where you see the major blood vessel, and ovarian cortex will have that ovarian type of stroma, and these stromal cells are sex cord stromal cells and regular stromal cells. WHO has classified tumors of surface epithelium, tumors of germ cells, and tumors of the stroma. In the tumors of the stroma, it is sex cord stromal cells and routine stromal cells.
Ovary panoramic view, stain HND, low magnification. First, in a mature follicle, they showed cumulus oophorus, primary oocyte, corona radiata, antrum, granulosa cells, theca interna, and theca externa. Next, medulla with blood vessels, corpus albicans, recent, cortex, germinal epithelium, primary oocytes and primary follicles, mesothelium. Next, corpus albicans old, tunica albuginea, corpus luteum, granulosa lutein cells, theca lutein cells, primordial follicles, antrum of secondary follicle, primary oocytes and secondary follicles, acretic follicles, and blood vessels in mesoovarium.
So we are having 3 cell types here. Germ cells, small round stromal cells are known as granulosa cells. Granulosa. Spindled out cells in the outside are known as theca cells. And probably this is ringing a bell now. Granulosa cell tumor, theca cell tumor, germ cell tumor. So they are all the neoplastic counterpart of the normal cells in the ovary. And these follicles, they will just rupture and remove this oocyte into the peritoneum, and they will be picked up by the fallopian tube, and then they come to the uterus and they get fertilized, and we are all here. After rupture, this will undergo collapse, and when they undergo collapse and when they are yellow in color, it is known as corpus luteum. Further degeneration, they become white in color, then they are known as corpus albicans. You can see the surface epithelium. Number 1, germ cells, number 2. And these germ cells without follicles, they are known as primordial follicles or primordial germ cells, more like surrounded by ovarian stroma, not by granulosa cell. When they are getting mature, they will be lined by third type of cell, which are granulosa cells, and fourth type of cells that are spindled out, and that is known as theca cells. And the background stromal cells, they are the cells that are having wavy nuclei.
Figure 19.5, ovary, primary oocyte and wall of mature follicle, stain, hematoxylin eosin, high magnification. 1 to the left, corona radiata. 2, zona pellucida, cytoplasm and nucleus of a primary oocyte, antrum, granulosa cells, intercellular follicular fluid, antrum, cumulus oophorus, intercellular follicular fluid, basement membrane, theca interna, theca externa, connective tissue.
All the germ cells will have prominent nucleoli. This is corpus albicans. And these corpus luteal cells, these are all highly progesteronized stromal cells. So they will have a very distinct cell border, and very distinct cell border, abundant eosinophilic cytoplasm, and vesicular nuclei. So these are known as decidualized cells or luteal cells. It depends upon where you see it. If you see it in corpus luteum, it is corpus luteal cell. And sometimes they may be seen in the extra ovarian site. In those areas, it is known as decidualized cells.
Figure 19.9, uterine tube, ampulla with the mesosalpinx ligament, paranomic view, transverse section, stain, hematoxylin and eosin, low magnification. 1
Very
is
good.
mesosalpinx ligament, 2 is arterioles, 3 is venules, 4 is outer longitudinal muscle layer, inner circular muscle layer, 6 is epithelium, 7 is lumen of the uterine tube, 8 is mucosal folds, 9 is lamina propria, 10 is interstitial connective tissue, 11 is serosa.
Which layer is absent, ma? Can you see? One layer is absent.
Submucosa, sir.
Super. See, these are known as mucosal folds, are known as plica, isn't it? And these plica are not sticking to each other. The minute they start sticking to each other, then it is salpingitis. And see how it is filling up the lumen. What happens when they undergo atrophy, or when they do that fertilization surgery where they block the fallopian tube, they will undergo a process known as simplification, where there are only very few mucosal folds or very few plica like this. So that is known as simplification. So sticking is salpingitis. Simplification is fallopian tube atrophy in cases of postmenopausal females as well as in sterilization. This is the highest power where you can see the nice cilia. Like epididymis, fallopian tube is also lined by ciliated epithelia. Now they are saying most of the serous tumors of ovary are arising from the fimbrial end of the fallopian tube. You see the close relationship of ovary and the fallopian tube here. So you remember we do prophylactic oophorectomy and salpingectomy in BRCA-associated tumors. So in those cases, you have to all embed the fimbrial end to see is there any in situ changes. Now we are done with the ovary, fallopian tube. We are coming to the body of the uterus.
Uterine wall.
There are 3 layers of the thing. Again, submucosa is not there in the uterus also. Okay, endometrium, myometrium, and then serosa.
Endometrium, there is a lining epithelium, lamina propria, coiled arteries, and uterine glands. In myometrium, we see smooth muscle, longitudinal section, smooth muscle in cross section, and functionalis layer, basalis layer, and interstitial connective tissue and blood vessels.
When you see the endometrial glands, in the endometrium, we get, as they are telling, we get the epithelium as well as the stroma. When you get the epithelium and stroma in the myometrium, what do you call, ma? Adenomyosis. What will happen to the endometrium? They will be shedding, menstrual endometrium. That's why there are 2 layers. Basal layer, which is preserved in even after shedding, and functional layer, which is shed every 28 days. Isn't it? So that shedding will produce lot of hemorrhage, and so the definition of adenomyosis is presence of endometrial glands, endometrial stroma, and hemorrhage with hemosiderin laden macrophages. This is the triad for the diagnosis of adenomyosis. When you see these three in the myometrium, it is called adenomyosis. When you see those three in the serosa or outside the uterus somewhere else also, then it is called as endometriosis. And this functioning layer, as you know, this is divided into proliferative phase and secretory phase. See, previously dating of the endometrium is very, very important. Remember, the first 14 days are follicular phase and next 14 days are luteal phase, and the 28th day it will menstruate, isn't it? And follicular phase is estrogen driven. The secretory phase is progesterone driven. The source of the progesterone is the corpus luteum. And previously, some patients will have infertility. What they are thinking, whenever there is a progesterone deficiency, the fertilization may not happen, or embedding the fertilized ova may not happen. So, the progesterone deficiency can be identified by endometrial curettage during the luteal phase. For example, day 18, they do the curettage. When you see the endometrium with the changes of day 16 on day 18, that means progesterone is deficient, isn't it? So that's how they used to diagnose progesterone deficiency, but now they can do it serologically. So the endometrial curettage dating of the endometrium is getting outdated now. So it is not very important nowadays. In the stroma, you see the spiral arteriole. Yes, they run like this, like a spiral. And when you cut like this, you see 1, 2, 3, 4, 5. That's why they are known as spiral arterioles. If you are lucky, you can see like this, and usually it is seen in multiple levels like here. So that is the spiral arterioles. Sometimes the stromal tumors may be difficult to differentiate from smooth muscle tumors, leiomyoma and stromal tumors. So we have a specific marker now known as CD10. Remember, I told you for that inverted microvilli syndrome also CD10. That CD10 is positive for stromal cells, whereas SMA is positive for smooth muscle. There is a lot of molecular changes are now coming into play in the stromal cells. The tumors of the uterus are tumors arising from the endometrial glands, okay, that is number one. Tumors arising from the endometrial stroma, and then tumors arising from the smooth muscle of the uterus.
Figure 19.16, cervix, cervical canal and vaginal fornix, longitudinal section, stain H&E, low magnification. Muscularis, epithelium of cervical canal, cervical glands, glandular cyst, cervical canal, os cervix, epithelium of the portio vaginalis, vaginal epithelium, vaginal wall, lymphatic nodule, lamina propria, vaginal canal.
So if you want to continue for anatomy sake, this will be the vaginal canal. They are also lined by stratified squamous epithelium. But the vaginal mucosa is undulating. Okay, that's one of the way to recognize it from the cervical. Otherwise, it's difficult to. If they take biopsy from the vaginal epithelium and biopsy from ectocervix, they may look alike. And another practical point you have to remember: the stratified squamous epithelium gets converted into glandular epithelium. The most important area is the transformation zone, the T zone. So any cervical biopsy, it has to show you the ectocervix, transformation zone and the endocervix. And only this is adequate. If you see only endocervix or only ectocervix, and if you don't see any lesion, you have to specifically mention the transformation zone is not seen. That is very, very important. Glandular epithelium is tall columnar cells with basally placed nuclei, and they look like a picket fencing appearance.
Figure 19.17, vagina, longitudinal section, stain H&E, low magnification, mucosal folds, Stratified squamous
Now,
epithelium.
these folds are the one what I was telling, like undulation. Okay, ma?
Undulating. Yes, sir.
Super.
Stratified squamous epithelium. Connective tissue papillae. Lymphatic nodule. Smooth muscles. Longitudinal bundles and transverse bundles. Adventitia. Lamina propria. Lymphatic tissue. Blood vessels. Interstitial connective tissue. Blood vessels and adventitia.
So, you know the ectocervix transformation zone I told you. So, the glandular epithelium will be tall columnar cells. Drawing the glandular epithelium in blue color, and I will draw the squamous epithelium in red color. And as I told you, the most important area is the transformation area. And if you see here, the squamous epithelium, this is the basement membrane of the squamous epithelium. These are made up of basal cells. The in-between cell is intermediate cell, and the most superficial is superficial cell. So, there are three types of epithelial cells in a cervical smear or pap smear. One is superficial cells, intermediate cell, and basal cell. And superficial cells are under the influence of estrogen. And intermediate cells are under the influence of progesterone. What happens here? Here they are telling vaginal smears collected during different reproductive phases.
A is post-menstrual phase, sir.
Okay.
And there are intermediate cells which are progesterone driven and superficial acidophilic cells which are estrogen driven. B is ovulatory phase. We have intermediate cells and superficial acidophilic cells, sir. C is luteal or secretory phase. Intermediate cells and superficial acidophilic cells. D is premenstrual phase. Intermediate cells, neutrophils and superficial cells, sir. And E is early pregnancy, conglomeration, intermediate cells and superficial acidophilic cell. And F is menopause, intermediate cell, basal cells and neutrophils.
They are going, forget about A. From B, they are going from the estrogenic phase rich to the progesterogenic phase. That's why the superficial cells are usually take a pink color, then they will have a pycnotic nucleus. Whereas the intermediate cells will have a greenish blue color and they will have vesicular nuclei. If you go to high power, you can see how pycnotic this nucleus and how vesicular this nucleus. And usually they show different colors, but it is better to go with the nuclear features. Even though they are very pink, not all the cases will take. So, when the pink cells are more, it is estrogen rich. When the blue cells are more, it is progesterone rich. And in menopausal, there will be atrophy. Both superficial and intermediate cell will be gone. You see only the basal cells with a lot of inflammation because of the atrophic vaginitis. Whenever you see dysplasia involving intermediate and superficial cell, it is low grade dysplasia. Whenever dysplasia is involving the basal cells, it is high grade dysplasia. Just remember that. So, which hormone is more in pregnancy?
Progesterone, sir.
So, what cell should be more during progesterogenic phase?
Intermediate cell, sir.
Okay, that's what you are seeing in the pregnancy. So, this is the pregnancy, no? What cell is more, green cell or blue cell?
Sir, blue-green cell, sir.
Or pink cell, which is more? So,
the intermediate cells, sir, the blue-green cells, sir.
Yes.